Okay, so today we're going to talk about the role of the RN in IV therapy. Okay, let's start out with just a little bit of history. Um, I don't expect you guys to memorize dates and all of these names, but I'm just trying to put this into perspective for you. So don't try to go down through here and remember that in 1667 was the first transfusion, and in 1970 was our when our plastic containers were developed. So I'm not worried that you know these dates. It's just putting it in perspective for you. So, in 1628, a man by the name of William Harvey discovered that our blood actually circulates. Now, before this, there were cultures that believed this, but Mr. Harvey is the person that was documented as discovering the circulation of blood. Because of this discovery, further experimentation started. But other ancient customs also believed in what we call bloodletting and the uses of leeches. Now, you guys know what leeches are. There's a picture there on your screen of that. If you could only imagine someone placing a leech on you to withdraw the bad blood, so to speak, from your body. After about 50 years or half a century or so, Mr. Harvey gave up, and the popularity of leeches actually soared until the early 1800s. And that's whenever we finally proved that these leeches are harmful and we don't need to be using them. And it still amazes me that it took us that many years to make people believe that leeches are harmful. In 1656, a man by the name of Christopher Wren injected opium into a dog intravenously. Okay, he used a quill and a bladder. And I believe that the bladder he used was actually a pig's bladder. And when you think of a quill, think of a porcupine, the quills that they have. So kind of like a needle-like. That's what he actually used to inject that dog. Then in 1662, J.D. Major made the first successful injection into a man. So that was kind of, I guess, the beginning of injection into man, when it all started for us. In 1665, a dying animal was successfully transfused with the blood of another animal. In 1667, a 15-year-old boy, I want to say from Persia, I'm not for sure, but I think it was from Persia, was the first human to receive a transfusion successfully. So they took this 15-year-old boy and gave him a blood transfusion. So the transfusion, the act of it, was actually successful, but they used lamb's blood, not human blood, but they transfused this young boy with lamb's blood. And of course, as you can imagine, he had many problems and eventually died because we are not compatible with lamb's blood. But the act of the transfusion was successful. It's just what we put in him was not. And I don't really know the history of this. For those of you who are thinking outside the box, which I hope that every one of you are, I couldn't really find out. I'm assuming that this young boy was on his deathbed and he was going to die whether it worked or not. And so they attempted this with him. But who knows back in those days. But I'm sure hoping that's the way it was. In 1687, which is about 20 years later, Europe prohibited animal-to-man transfusions. So again, it took humans 20 years to figure out that just wasn't a smart idea. Kind of worries a person. In 1900, a man by the name of Dr. Carl Landsteiner proved that not all human blood is alike. So in 1900 is when we discovered that we need to type and cross because not all of our blood is alike. In 1935 is when we developed our slow drip. In 1945 is when the plastic catheter was developed. Before that, we used those metal IV needles. This was prior to World War II. So anyway, that wasn't that long ago. For some of you who are in your 20s, it may seem like a lifetime ago, but really it wasn't. That was less than a century ago. So it wasn't that long ago. In 1970, we changed from glass containers to plastic containers, and this was really a big development for us. Now, you will still see glass containers, medications that are in those in the hospital and when we administer medications, but that has to do with the stability of the drug. One of the drugs that you'll see in a glass container is nitroglycerin, and that has to do with the stability of that, and we'll talk about that at a later time. So there still are glass containers, but for the most part, most medications are now in plastic containers, which is great because you can't break those, right? Um, and of course, IV fluids have been widely used since that time for about probably 70, so we're going on around 50 to 60 years for that. So again, I don't care that you guys memorize these dates, so don't try to memorize these for future testing. I just want to put into perspective for you of how far we have come with IV therapy. All right. So let's talk about the role of the RN and all of that we just talked about. In 1930, we used IVs for only the critically ill, and only a physician could insert them, and nurses assist the physician. In 1940, finally, a hospital in Massachusetts was one of the first hospitals to assign a nurse as an IV specialist. And the only thing that nurse did, her sole responsibility, her only job, was to maintain equipment and skillfully insert an IV. That's all she did all day. Now we know in today's world that would never fly. Even our IV nurses now have so much more to do than just that. But when we first started this in 1940, the sole responsibility was to maintain the equipment and to be able to skillfully start any IV. As more IV solutions became known, then obviously the nurse was expected to know more. Today there are more than 200 solutions. There are, I would venture to say, close to 1,000 solutions out there. The specialty of IV nursing is throughout nursing, and nurses are constantly looking for more efficient ways to perform those injections. So some facilities still have IV nurses that their only job is to do IV therapy. So because of all the IVs, infection rates, and all those things that go on today, their specialty is that. So they don't actually work a floor and care for a cohort of patients. They go throughout the entire hospital and do that. But we know that their job entails much more than just sticking in an IV and walking down the hall. Just a side note, not that you guys really need to know this, but on October 1st of 1980, our House of Representatives recognized the profession of an IV nurse and declared it an official day of honor for IV nurses. And every year on January 25th, we celebrate National IV Therapy Nurses Day. So that won't happen during our fall semesters, but if you're in the spring semester, then you'll be here on our IV Therapy Nurses Day. Okay, so what do we know about the role of the RN today and how it has changed? Our role today is set by what we call the standards of practice, and that is outlined by the INS, and INS stands for Intravenous Nurses Society. And they're who we make our practice guidelines. Every facility goes by that to make them. For the nurse, for our role, first, for IV therapy, it's incorporated into our plan of care. So you guys know all about your care plans, and that IV therapy is a big part of that. Initial assessment to ensure the selection of the appropriate site for our IV order. So we're going to talk about assessment here in just a bit, but you as the RN have to assess that site. You have to make sure you have the correct site. You have to make sure that you have the correct therapy that is ordered. And by doing that and knowing what you're doing when you do that, it will ensure that we have positive outcomes for our patients. IV therapy is initiated for two purposes, one therapeutic and the other for diagnostic. So there's two different reasons that we would give IV therapy, and obviously we have to have a physician order for that. We can't just say, oh, I think they need that, stick it in them and give it to them. we're not quite there yet with our education. Okay, so the RN is to complete the initial assessment. I told you we'd talk about that. So we're to complete the initial assessment. We need to obtain an order for initiation, and we select the site. Okay, where are we going to put this IV before we even do the IV therapy, which is the medication that is going through that IV. Okay, that can entail your patient's condition, obviously, their age, their diagnosis, their vein condition, the size, location, the type and duration of the therapy, and other therapies already in progress. So maybe they already have an IV infusing and we need to give another one. So we have to assess them and we have to be able to make that decision as to where we're going to put that second IV. As a nurse, we have to be able to select the correct cannula. We have to be able to prepare the site. We used to shave it. Now we clip it. They don't recommend shaving anymore. We clip the site if the patient has a lot of hair in the area that we want to use it. And we have to cleanse that site prior to initiation. As the RM, we are also responsible for dressing changes, tubing changes, monitoring it, changing our sites as per policy, and discontinuing the IV and the therapy if ordered or as per order. That includes the cannula, the site, the patient response to treatment, the type of treatment, the date, the time, and the signature. Documentation is a huge thing with IV therapy, as it is with any other aspect of nursing. And when we document, we must document the type, the length, the gauge size, the date, the time, the location, and the number of attempts. Okay, and we'll discuss each of these more in detail as we cover the topic. We'll talk about that. And when you guys check off for IV insertion and IV fluids, you will document at that time. But it's very important that we document every aspect of that. And I know from you guys being in skills and pharmacology that you've had lots of practice with documentation, and so you should know that. You have to just think about, what am I doing with this IV, and you document everything that you're doing with the IV. As an RN, you're also responsible for patient teaching regarding the care of the IV and home care. If the patient is going home possibly with a PICC line, and we'll talk more about central lines later on in the semester, but if they are going home with a line, then we need to give them patient teaching regarding that as well. The nursing process, I know that you guys know this well, so we'll just briefly mention that here. The nursing process is encompassed during IV therapy, as it is with everything we do in nursing. Assessment is the first one. That entails your subjective and your objective. Subjective things for IV therapy may be the fears of it, prior experiences with IV therapy. Perhaps they had a nurse or a lab tech or someone who stuck them in the past, and now they have this huge fear of it and they're not wanting you to stick them. So we need to make sure we're assessing their prior experiences. Preference of site. Maybe they're right-handed, so they really would prefer that you had that in the left hand if the therapy itself allowed for that, and most of the time it does. So you want to make sure that you include your patient with that, the preference of site. Objective, physical assessment, lab data that you're going to have to look at, medications that we give, we need to look at our labs a lot of time with that, TPN, PPN, things like that, and of course the type of therapy used. All of that would be objective. Okay. Diagnosis. Nursing diagnosis is used to describe the patient problem with our IV therapy. For example, perhaps we're giving someone an IV for fluid volume deficit. Okay, maybe they're dehydrated, so we need to give them fluid. Okay, so that could be an example of a diagnosis that we would use, fluid volume deficit. For planning, what nursing action are you going to complete, such as preventing complications? Okay, so what are you planning for this patient? Implementation is putting into place the actions that you place in your care plan. So what are you planning? Now we're going to implement that plan and we're going to put it into action. And then of course your evaluation. Did it work? If it doesn't work, then what are we going to do about it? So for example, if we used fluid volume deficit as our diagnosis and we plan to administer IV fluids, and then we received an order administered the fluid, then we would evaluate that and say, is my deficit better? Is it same? Or is it possibly worse? And what do we do now? So you will learn throughout this semester that as the nurse, yes, we have to know about the medication that we're giving, but we also have to know about what we're going to do if it doesn't work, or what if it works a little bit differently than what we had anticipated. So we not only need to know the side effects of the medication that we're administering, but we need to know the treatment for the good and the bad of the other side of that. All right, informed consent. You guys have probably heard this before, and I know that we talk about this in MedSurg too as well. Informed consent must be confirmed before we can initiate IV therapy. Obviously, we can't go in and start giving patient all this medication without them saying that they will take it. Now, with a saline lock, when they come in and they're admitted, that is on their orders and on the physician orders, and verbally we speak to the patient about getting the saline lock, so we get verbal consent from them. But if we give the patient blood, if they have a central line placed, and again we'll talk about central lines more in detail toward the end of the semester, but those things have to have informed consent. They have to be permits that are signed and placed in front of the chart for all other staff to see. Criteria for informed consent: the patient must be mentally competent and capable of granting that consent. So make sure that your patient is mentally competent. They must be of legal age, or the parent of a minor, or a POA, okay, someone who is in charge of that patient. The patient must be able to understand English if they're here, or we must get them an interpreter. Okay, so they have to be able to understand the language that we're communicating with them, because how many times have you gone to the doctor maybe with a parent or a grandparent? That was my case, my grandparents. When the physician would come in, they just nod their head and say yes, but they didn't understand a word that they said. So you want to make sure that we're using the proper language and that they're understanding what we're saying to them. Clear information about the procedure must include the benefits and risks. This is what the benefit of this medication is. This is the risk of it. This is what could happen, even though we're trying to help you. Any alternate procedures, okay? This is what we're going to do, but this procedure over here could be done, but it may or may not benefit you in this way. So the benefits and risks of the alternative procedures must be presented to the patient as well. The risk of refusing. So perhaps you go in to tell the patient that they need this and they want to refuse that. Well, that's their right to refuse it, but it is our responsibility to tell them that if they refuse this, this is what could happen. So we could give you this treatment and this is your chance of survival, or we could not give you this treatment and you have a 100% chance of death. Maybe not that abrupt, but we do want to tell our patients that they have to know the risk of refusing as well. Qualifications of the provider, we need to know. Can a nurse aide just come in and stick an IV in you? So you want your patient to know that, yes, I am the RN, yes, I have been trained for this, and I do have qualification to do that. And as the RN yourself, you need to know who is able to start an IV. Can the RN start an IV? Can a physician start an IV? Can a CNA start an IV? Can an LPN start an IV? You need to know that. And then signature on an informed consent must be on the chart, or a waiver of that consent. If they have refused, it still has to be signed saying that they have refused the ordered treatment. Legal issues. Okay, what do you need to know? You're the nurse. These things, I hope, go through your head. Can I legally administer IV therapy? Can I legally give this drug? Chemo is an example. When you graduate nursing school, can you walk into the hospital and administer a chemo drug? Think about that. Do you know the answer? You have to be a nurse for a specific amount of time before you can even certify for chemo medications. So you cannot just walk in and administer IV chemo medications. So you need to know, can I legally administer these medications? So when you're giving medications when you graduate, you need to ask yourself that. Does my state delegate this to a nurse? Okay, so does my state say, as an RN, I could administer this? As an LPN, I may or may not have been able to administer this. We know that LPNs in the state of Missouri cannot administer IV push medication of any kind. So we need to know that. Are nurses limited to the types of IV therapy that they can administer? And again, that kind of goes back to the chemo there. Is there an order for it? Because I've already told you that you have to have an order for any medication that we give the patient. And is the nurse qualified by their education and experience to administer the IV therapy? It's just very important that you understand what you can and cannot do as a nurse, and that you're very knowledgeable in that, because I guarantee you, if you do something incorrectly, the lawyers are really not going to care that you thought you could do that. And truly, the patient wouldn't either, and you wouldn't either if that was your mom or your child especially. Okay, other legal issues, malpractice, that's a huge thing in the medical field, in nursing. Malpractice is rising. IV therapy, as you can imagine, carries a very high risk of this, because if it's done improperly, patients can lose limbs, their livelihoods, death. People die from this. Now, all medication is serious, and it's imperative that you know everything you can know about every medication you administer to your patient. But with IV therapy, it's even a little harsher, because there is no take back with IV therapy. Once you have pushed that into a vein, it's done, it's gone, and you're hoping for the best. So it is imperative, I mean, I can't stress this enough, that you know exactly what you're doing before you do it. It is life or death situation. Other things that could happen and that affect that malpractice: nerve damage, infiltration, infection is a huge thing with IV therapy. And those infections can become septic, which is an all-over infection, bloodstream infection, and people can die from it. So it's very important that you pay attention to what you're doing and you know what you're doing. If you don't know what you're doing, you don't do it. Nurses have a legal responsibility to be knowledgeable about the IV treatment they're administering, the things that they're monitoring, the identification, and the intervention in case there is a complication. And I've said this before, that it's not only do you have to know what you're giving, but you have to know the treatment or how to respond if that medication doesn't go the way that you want it to. Okay, with patient teaching, nurses are responsible for patient teaching, including the teaching methods, the assessment of the health literacy, and evaluation of that learning. So as the nurse, you're responsible for going in and teaching that patient. You're responsible for making sure the way that you are teaching that patient is understandable to them. I believe that they now say that, like, our pamphlets and things that we give patients have to be at a 5th grade reading level because of all the different dynamic in our population. So it's your responsibility as the nurse not to go in there and just talk like you're talking to another nurse or to a physician, because 9 times out of 10 your patient's not going to understand you. So you have to make sure you're able to give them clear information. And as the nurse, you have to be able to evaluate what you just told them and see if they understand everything. And they're not just like grandpa and grandma and sitting there nodding their head yes because they don't want to say that they understand. It's very important. Factors such as their age, cognitive level, developmental levels, perhaps their culture, language, those all have to be taken into consideration whenever we're doing patient teaching. And never use medical jargon, what I call it. Never use medical language with your patients that they can't understand. Don't use acronyms, okay? Thanksgiving dinner, there are 3 of us that are nurses in the family, and my mom and my aunts are always asking us to please talk English, because we'll get to talking about our jobs and we use, you know, IV and CAD and EKG, and all CBCs and BMPs, and they're like, what in the world? Don't talk to your patients like that. Make sure that you spell everything out for them. So don't ever use medical jargon with them. And we'll discuss patient education with every skill that we do throughout this semester. You'll know what you need to teach your patients.